is a very short session of 30 minutes. I will start. Can I have my presentation, please? Okay, so I'm going to take 3 or 4 minutes to give an introduction to this particular topic. So I do not have any financial disclosure to relevant to this. These are my financial disclosures. And if you see a myopia at this point of time, in this graph, excuse me, in this graph, you can see from each of the continent, probably the severity is increasing. In some of the places in the world, myopia is at a lower prevalence. If you look into Southeast Asia, it's almost reaching to 90%. But one thing which is very clear in this particular slide is everywhere it's on an increasing trend. So there is a paper from Brian Holden. It says that the prediction could be as high as 50% of the children can be myopic by 2050. So that's the way the projected thing. That's why in each of the location, wherever you are, even within India, wherever you are, the trend is increasing. We haven't reached 90% or so yet, but it's on the increasing trend. So what are the typical factors we need to consider in myopia management? First is, can we prevent the development of myopia? That's the number one. And once you have the myopia, can I look at high-risk characteristics of these patients? And can I look at halting the progression of this so that most of these people, when they are 20 years or 30 years, they don't go into the pathological group. So that's the three stream of things we need to look at when you really manage myopia patients. So this is my last slides. I'm just going to give a very comprehensive management strategy for patients with myopia. So you have to do some basics checkup along with refraction. You need to look at the axial length. You need to look at the alignment. You need to look at the torchlight examination and a comprehensive evaluation of the eyeball. And I also put pedigree because family history and the screen time and for everything is important. And also sunlight exposure and the refraction, we need to do it. And the first and foremost thing, what everybody can do is a behavioral change in the child. What is those behavioral changes? Two things. One is reduce any kind of screen time. Second thing is increase the outdoor activities. This is a baseline for every myopia management what you put to a child. This is not an alternative. Many parents and many children will argue in the clinic, oh, I am using these glasses, I am using these drops. This is not replaceable. This is in addition to the behavioral modification. That's the right thing to do. Then we have glasses. Many people have a belief that undercorrection is the rule. Never. Give a full correction of myopia. Then you can give drops if there is no peripheral hyperopic component. If you have peripheral, if there is esophoria, you can give bifocal. If there are peripheral defocus is happening because there is more hypermetropia, that's the stimulus. You have to use this peripheral defocus lenses. And then orthokeratology can be used in little bit older children where a management of myopia as well as prevention of progression can happen. And sunlight, always respect the sun, which you used to do in the past. Respect the sun because get up, and even in the night time, what has changed in the last few years is sleeping time of the children and even parents has changed because we have electricity. So try to respect the sun And you can use drops, you can use peripheral defocus lenses, or a combination of that if you still find the progression. So success rate of either you drops or you use defocus lenses, it's somewhere between 50 to 60%. There are still some unanswered questions, but this gives a comprehensive management. How do you want to take care of this? And you can take the QR code. It will directly lead to a document by World Society of Pediatric Ophthalmology, where it tells you what are the options available at this point of time for myopia and what works and what doesn't work. Thank you very much.
Can I have my slides, please?
So I invite Dr. Kunal Srivastava to talk about one of the options for myopia progression management, the scientific insights from the peripheral defocus lenses. Over to you, Srivastava.
Thank you so much, Ramesh sir, and thank you, APO AIOS. I'm really honored and humbled to be on this dais. In next around 7 to 8 minutes, I'll quickly walk through as to what is the design and what have been the clinical outcomes. So let's get to it. These are the disclaimers. This is for educational purposes only, not promotional. Let's look at what is Essilor Stellest design. Now, one thing that is there is you have to give correction, and this is what is the basis of it. You have correction, let's say from -1 to -12 that you have. But along with that, you also have treatment zone. Now, these treatment zones are based on 11 concentric circles, which are made up of highly aspherical lenslets. Now, there are 1021 lenslets, there are 11 rings. Their asphericity is same in each ring, but it differs when you move from inner to outer rings. How does it work and why exactly we are having highly aspherical lenslets? Let's focus through one lenslet. Now, these are highly aspherical, so when light rays fall through it, rather than being in one single plane, they form a volume of myopic defocus. Now let's imagine one ray of light falling through it and how it will form a myopic defocus. Let's call it the microelement. But we know it's never one ray, it's a beam that goes throughout. So there are multiple beams, and eventually what we get is a macro element of volume. So if we are using a Stellest lens, you are getting the good correction. Along with that, when we combine this micro and macro element, what we get is a shape of volume of myopic defocus. Now this forms kind of a shell right in front of the retina and in the shape of retina because of how all the rings and asphericity is decided. So actually, if you see, this is how it looks like. And because of the design, how it is, you have around 40% of treatment zone and 60% of correction zone. So it doesn't matter what is your gauge, you are going to get sharp central image, and you are going to get a very good signal of volume of myopic defocus. That is a signal to stop the progression of axial length, and thus helping in controlling the progression of myopia. Now, one question that also comes into our mind, what happens to visual performance and how good is the adaptation? Now, in our study, progressive 2-year randomized control trial, what we saw is that almost 90% of children, they got adapted to this lens within 3 days, 100% within a week, and more than 94% they felt really comfortable with these lenses. Not only this, there have been several studies. Some have been investigator initiated, some have been post-hoc analysis, but when we look at the visual performance, in comparison to single vision lens, whether we are looking at visual acuity, accommodative lag, accommodative amplitude, neophoria. So this one study where we looked for 1 year, there was no actual difference. When looking through halt zone, now this was one study which was conducted in actually adult population. Through halt zone, what is happening to visual performance, and there was no significant, clinically significant difference. If you look at high contrast, the change was 0.07 log mar plus minus 3. That is like one line, we're going above it. Other than that, looking at peripheral measure of vision like contrast detection, peripheral global motion processing, usual field view, these are all unaffected. And not only this, last year at AIOS2024, we presented a paper that was post-hoc analysis of our 2-year clinical trial, and that we are looking at cornea, we are looking at the cylindrical, we are looking at astigmatism. There's no impact of Essilor Stellest lens on these factors. So it is the visual component that we have seen. We are not seeing any impact over there. We'll quickly go through the clinical evidence. Now, this was a randomized control trial, progressive, for 2 years, which was in Guangzhou, China, and the age is 8 to 13. We can see the inclusion, exclusion criteria, and so on. At the end of 2 years, in terms of myopia progression, SER, it was better as compared to single vision length by 0.8 diopter, and in terms of axial length by 0.35 diopter. Not only this, for the subset of children, those who are wearing these lenses for more than 12 hours, it further improved to 0.99 diopter on an average and 0.41 mm in terms of axial length on an average. Then, not only this, 9 out of 10 children, those who are wearing these lenses for more than 12 hours, after 2 years or within 1 to 2 years, their eye growth was quite similar or even slower as compared to non-myopic children. And that is a big win in terms of a 2-year study where we found. And it was clinically significantly better as compared to single vision length. But then we decided, let's extend the study and to 3 years and 5 years. I'll quickly move into the 5 years result. In 3 years, although we were in ethical dilemma, how can we put the same children when we have seen clinical benefit? So we decided we'll recruit another well-matched group. After 3 years, again, we wanted to extend the study to 5 years to give long-term results. But this time we decided, let's go for an extrapolated control group, looking at the studies by Champ and Smotherman et al. As to how axial length changes over year and time, and how your SER changes over year and time. Based on that, it was extrapolated based on the actual 2 years control group. The results were very promising. By end of 5 years, in terms of progression, Essilor Stellest lenses actually slowed down myopia progression by 1.75 diopters. Now that's a big win. It was significant as compared to single vision length. In terms of axial length, again, it was 0.72 millimeter better as compared to single vision length. Now, this is one way of looking at it. Let's try to look at it another way. Let's try and see how long it took for the children, those who are on single vision length, to reach to the same par or axial length. At the end of 5 years, with Essilor Stellest, we reached minus 1.27. But those who are on single vision, they reached there in less than 2 years. Similarly for axial length. So another way of looking at it is Essilor Stellest lenses actually saved around 3 years of myopia progression. To conclude, I'll say Stellest lenses slows down myopia progression by on an average by 67% based on 2 years result. At the end of 5 years, what we have seen is the progression slowed down by 1.75 diopters and 0.72 mm on an average in terms of axial length. And not only this, by the end of 5 years, the children what we recruited were 8 to 13 years. By end of 5 years, they were between 13 to 18 years. Over there also, we have seen slowing down in the progression with the use of Essilor Stellest lenses. So thank you, gracias, for your patient listening.
Thank you, Kunal, for that comprehensive presentation. Now I invite Ms. Fu Li Lian. She's going to talk about clinical best practices. Over to you.
Good morning, everyone. Thank you for coming for the lecture today. I'd like to thank Essilor, Dr. Kuna, organizing committee for the opportunity to be here, and thank Dr. Ramesh for the very kind introduction. So today the talk will be presenting on best clinical practices, particularly in implementing Stellest for myopia management. So these are my financial disclosure. So as mentioned, I'll be talking about the best practices using Stellest Essilor lenses. So what exactly is Essilor lenses? I believe Dr. Kuna has mentioned earlier, is basically controlled through the hot zone with 11 concentric rings of contiguous aspheric lenslet and generates a volume of non-focus light where slow down signal is in front of the retina. I'm going to present this study that was performed in Singapore National Eye Standard. It is a study basically about combination therapy, combining Stellest Essilor lenses with atropine therapy itself. And whether or not this will help to slow down the children in terms of myopia progression compared to just low-dose atropine alone. So the inclusion criteria in this study comprise of myopia -1 to -6 diopters, astigmatism of less than -2 diopters, children of 6 to 12 years old, and patients who are only on low-dose atropine, such as 0.01 as well as 0.025, with good compliance. And they must also have myopia progression of at least 0.5 diopters in at least one eye for the last 6 months. So what are the demographics of these patients that we have recruited? So the types of the study that we performed was a prospective, non-randomized controlled observational study. We recruited a small number of subjects, which is 50 participants, aged between 6 to 11 years old, with a mean age of about 9 years old, and gender-wise, about 40% of them are boys. We have a mixed ethnicity in Singapore with majority of the Chinese, and hence the subjects we recruited are very reflective of the population that we have in Singapore, with close to 90% of them are Chinese, as well as including Malay, Indian, and Eurasian. Atropine usage in these children comprise of 0.01 nightly, 0.01 twice a day. Usually we advise them to use morning and night, as well as 0.025% once every night. The data we have collected comprise of pre-treatment, which we collect the spherical equivalent and axial length data 6 months before the study, and treatment-wise, we collect during baseline 6 months as well as 12 months in terms of both spherical equivalent and axial length. What are the key results that we have? If you look at the chart, you can see that once we started hot lenses on the left-hand side, which is spherical equivalent, and on the right-hand side, change in axial length, there is significant in terms of slowing down the rate of progression in both spherical equivalent as well as axial length in these children after adding on hot lenses on top of their low-dose atropine. So in terms of numbers-wise, here are the results. Spherical equivalent and axial length. Pre-6 months is minus 0.6 diopters and 0.24 millimeters. And you can see the significant in terms of slowing down the rate of progression at 6 months and 12 months after adding on Stellest Essilor lenses. So in terms of percentage-wise, it is close to 90% as well as 75% at 6 months. And also taking average, it is about 75% in terms of spherical equivalent reduction and 42% in terms of axial length reduction. And if you look at the spherical equivalent change as well as the axial length change, there is a shift in terms of hyperopic shift, slowing down the rate of myopia progression. You can see that the mean spherical equivalent is shifted to the right side, and change in axial length is shifted towards shortening once we add on the hot lenses on top of children who are already on low-dose atropine but have suboptimal progression. We do know that there are still 20% of the children who still progress more than 0.5 diopters over the last 1 year, and 18% still progress more than 0.3 millimeters in terms of axial length, and 40% progress more than 0.515 millimeters over 1 year. But having said that, we do know that children do tend to have some form of progression because they are still growing, and there's a baseline in terms of progression for these children whose axial length will still continue to progress to some extent. Based on multivariate analysis, the change in axial length, we found that they are greater for those patients who are on higher dose atropine. So for example, for children who are on 0.01 twice a day compared to 0.01 once a night, as well as those who are on 0.025% atropine. And also the change in axial length are also greater in younger children with smaller pupil size. After controlling various variables such as baseline spherical equivalent, gender, ethnicity, as well as baseline axial length. How about in terms of glare as well as peripheral distortion? Do these children experience any of this, you might wonder, after adding on the Essilor Stellest lenses? Well, there's no significant difference, if you can see, in terms of the p-value before and after adding the Stellest on top of their low-dose atropine eye drops. So of course our study have limitations. Besides the small sample size, there is no control group in our study. It is a short duration of 1 year, and also it's not randomized control trial, and patient also can have variable atropine compliance. Sometimes some patients may skip 1 to 2 days, whereas others may be fully compliant to the eye drops. So next I will discuss 2 case scenarios that can be applied to your clinical practice, and these are the real patients that I see in my clinic. First is a 10-year-old Chinese boy. Parents have high myopia and has been using brand X of myopia control lenses. So you can see while using brand X myopia control lenses on the right and the left eye, patients were started at -2.5 diopters and -2.25 with axial length of about 23 millimeters respectively. So when I see the patient, the next visit, patient has progressed to -3.25, -3.5 with corresponding increment in terms of axial length. So what are your thoughts in your practice if you encounter this patient? What will you do to manage? Will you add on atropine eye drops? Will you change myopia control treatment, say to myopia control contact lens, and so forth? So in this case, I changed the patient from a brand X glasses to Stellest Essilor lenses, and you can see that the slowing down of myopia progression is significant. Patient, after switching treatment, has stability in terms of degree itself or minimal progression. So what this case emphasizes is that using one myopia control lenses, if it has suboptimal treatment, doesn't mean that all the other myopia control lenses doesn't work, because each myopia control lenses utilize different technology in slowing down the progression, and every child responds differently to different treatment, different brand of treatment. So you can always try to change the same modality such as myopia control glasses, but a different brand itself. So this is therapeutic switch. Next case, I'd like to talk about this 8-year-old Chinese boy. Low myopia to begin with is about -1 diopter, -0.5 diopter in the left and the right eye respectively. So following up the patient over the 6 months, we realized that, okay, patient have slight increment in terms of myopia axial length itself, and degree is the same. So decision was made at this point in time to just monitor first. So the next treatment, next visit, patients come in and we realize that, hey, patient has progressed from -1 diopter to -1.5 diopters in both eyes. Decision was made to start the patient on atropine eye drops, 0.025%. So looking at the patient's response initially, yes, there's slowing down in terms of the gradient. If you look at the gradient wise from initial till now, after starting the eye drops, there's slowing down. But yet, patients still continue to have slight progression, -0.25, and also axial length continue to increase. Because of suboptimal response to low-dose atropine alone, what I did for this patient, I add on the Essilor Stellest glasses. And you can see that after adding on, the gradient continue to slow down. Patients eventually have stability in terms of myopia progression itself while on combination treatment, low-dose atropine as well as Essilor Stellest glasses. So that's the end of my talk. I'm happy to take on any further questions or any cases you would like to discuss. Thank you very much for your kind attention.
Thank you, Dr. Fu, for that wonderful presentation. We started probably 10 minutes late, so there are few questions. Yeah, go ahead, please. All these lenses are available. I think the cost,
Yes, sir, it is available and it costs somewhere around 16,000 per pair. 16,000.
yeah.
Yes, sir.
There was one question, yeah. Can you come down to the mic, please?
So the question is to all three panelists. Would you start these myopia control glasses as a monotherapy in the beginning? Because Dr. Lillian presented her cases of add-on therapy. So what is your opinion about starting them as a first-line therapy instead of drops?
Yeah, probably we'll start with Dr. Leah.
Thank you. I think that's a very great question from Dr. Tamaye from Pune, because whether do we institute combination therapy right from the start? The short answer is yes, we do, especially for patients who come into clinical practice with significant progression, high myopia, and several other risk factors such as parental high myopia with even complications such as retinal detachment. In such cases, we do not have time to lose to start monotherapy right from the start and adding on and let them have a chance to have progression. We just start with combined therapy and monitor and see how they are progressing with this treatment.
Yeah, I also kind of agree. If you have a high risk characteristics of the patient, when we say high risk, parental history of very high myopia, child sibling is high myopic, and then the child's age is somewhere around 4 or 5, you still cannot start probably pharmacological. Probably there we can start optical. Maybe when the child is getting to the age of 5 or 6 years, we can add. And also, there is one more modification. You can also go for higher concentrations of atropine. So these are the 3-4 things we need to think. But primarily at Teleprasad, what we do is if patients has a peripheral hyperopia component, then we go in for more of a defocus glasses. If they have a pure axial, then we will do more in terms of pharmacology. That's a very short customization I'm explaining here, but there are exceptions. So how many of you in the audience manage myopia progression? Show of hands, please. Okay. So I think in 2025, there should not be any reason that any of this combination of treatment or monotherapy should not be instituted for the myopia patient. So it's very important that we explain the parents and explain the clinicians. There are options to control the progression. Yes, sir.
Is there any problem with 0.25 atropine, like pupil size, because of the pupil size?
Which concentration you are talking about, sir? 0.0?
0.25.
The pupil problems are mainly with the higher concentration. What we generally use in India is 0.01%.
Yeah.
It usually does not cause. When you say usually, more than 99%. There are some case reports,
No,
some
I'm talking
glare.
of 0.025.
Yeah, not much, sir. I think you want to answer?
Yeah,
Point.
sure, Dr.
Yeah.
Ramesh. So basically, based on our clinical experience with 0.025, it is generally very, very well tolerated. Although it is close to 0.01, but less than 10% of the children do experience some form of side effects. However, they are tolerable, which implies that they do not need any photochromatic glasses or any bifocal progressive lenses to help them overcome these side effects.
Yeah, it again depends upon which location you are, what's the color of the iris. If you go into Caucasians and whitish iris, it can cause. But generally, we don't see that. Yes, please, there are one by one.
So what is the range of myopia? Like in one of the slides, you show 1.5 to 6 diopters was the study. So what is the bottomest, like 0.5 up to 6 or 7, 8? Which patients we should advise? Like, is there any golden
Okay.
rule?
There is
Okay, which
no range of myopia where you should not treat.
Okay.
Any myopia which you see a progression which is documented,
Okay.
that person needs treatment. I also want to caution everybody that you have to look into only pure axial. It does not be useful in keratoconic myopia or any subluxated. So any range we can start, but the thing is you have to see a progression in them. So you could take any of these measures. And it's not that, okay, after 10 years I will not use any anti-myopia strategy. You can use that as well.
What is the upper age limit of the patient?
There is no upper age, sir. We are seeing more and more patients beyond 18 years also. They are coming up with progression. But generally, most of the patient at around 5 years or 6 years, we start this process. And it's a very long-term process. It's not that for 6 months you use and then stop it. It can go to 4 years or 5 years once you start it. So there is no real cutoff. Go ahead, please.
Sir, is there any cycloplegic effect seen in on using atropine 0.01%? I have seen one case a patient was not able to see the near.
Yeah, that's what I said. Very rarely, near vision can be affected. Very rarely, 0.01% or 0.1% of the patient can have. And there are case reports where it can lead to even convergent spasm, or there are very few reports that there are accommodative esotropia. So these concerns are there, but generally it will not cause. It's pretty safe dosage or a concentration of atropine to use in these children. We'll go ahead with that gentleman and then we'll come back. Yeah, you can go to the mic. Yeah.
Good
Yes,
morning, sir. Sir, you had mentioned the behavioral modifications
Yes.
such as reducing screen time and increasing outdoor time. So how effective is this? And secondly, the thing is sleep, respect the sun you had said. That means follow the circadian rhythm, go to bed early, avoid exposure to ambient light at night, and also they say switch off the bed lamp at night. So how effective are these in
Yeah.
slowing down the myopia progression?
Very good question. The best evidence is available in terms of modification of lifestyle is before the onset of myopia. Having said that, even after the onset of myopia, one should not forget the behavioral modification. As I said in my presentation, many people say, okay, I'm using this anti-myopia strategy, let me close the behavioral. That still continues. And what you said, that light and the posture, all that has to be good. If somebody, most of the kids will have studies even after 7 o'clock. It's not that they will switch off at 6:30 or so. So 2-3 things we need to be remembering. One is a good lighting system, good posture, and many people sleep and lie down and read. That way it can decrease the distance of the, your reading distance. That is also not good. So you need to have a healthier habit for this reading also.
Sir,
Yes.
after LASIK operation for myopic shift, should they be used?
I don't think so. We have evidence. You are talking about more than 20 years of age.
Yeah.
So
After lesson.
probably, I don't know, maybe there is a scope for orthokeratology because it all depends upon what is the corneal thickness, lot of factors. But I don't think so there is much evidence in those cases.
Okay. Thank you, sir.
I think because of time factor, we have to close here. I'm sure there are a lot of questions. We will be available outside. We can answer some of those questions. Thank you very much for the session, and thank you for the speakers. Thank you very much.